Okay, so today we are going to discuss the cases of preterm labor or premature, preterm premature rupture of membrane. Okay, so let's say that a female comes to you at 35 weeks with excessive vaginal discharge. How are you going to approach this patient? Basically, she should be approached immediately, and many things have to be done simultaneously. But theoretical point of view and long case, with respect of long case, we are going to discuss it under history and examination. So, what are you going to ask? 35 weeks before term is at 37 weeks, and if it is from 34 to 37 weeks, if labor is induced, then this is late preterm labor. Preterm labor is also divided. When it is before 37 weeks, it is preterm labor. What is going on? Yeah, it is going to preterm labor when it is before 37 weeks. But when it is from 37 to 34 weeks, then in that case, this is known as late preterm labor. And when it is before 34 weeks, then in that case, it is called as early preterm labor. So preterm labor is also divided into early preterm and late preterm based on whether it is before 34 weeks or after 34 weeks. And preterm labor broader definition is always before 37 weeks. Okay, so she is before 35 weeks. So you're like, she might be undergoing labor, she might only be undergoing rupture of membrane and labor has not started yet. So what are you going to ask? And the second complaint is excessive vaginal discharge. So you basically are going to ask her about any kind of signs of labor onset. Okay, for labor onset, you're not going to ask her, has labor started? No. Ask her whether she's having any abdominal pain or cramps, any sort of pressure, any sort of she is having, she might have painless tightening of her uterus. Also ask her whether there is painless constriction, a feeling of constriction or tightening around the uterus. Okay, also ask her about painless pressure or tightening for labor. And then you also have to ask her about her vaginal discharge. The presenting complaint is vaginal discharge. So first we should approach that what was the color and amount and any kind of smell, foul smell. Why am I asking about foul smell? Because there can be coexistent chorioamnionitis. So to rule out chorioamnionitis, I'm asking out infection, chorioamnionitis, I'm asking about foul smell, and that is a separate entity. I'm going to ask these questions later. Okay, color, amount, any kind of blood. Why blood? It can be placental abruption, you never know. But in that case, the uterus would be tender and tense, a woody uterus. Okay, I'm just telling this, woody uterus for abruption. So this is not an abruption. She does not have that tense and tender uterus. Rule out. Okay, color, amount, blood, and we're going to ask her about any associated symptoms. Okay, and did it happen before? We're gonna ask her. So basically, color is, let's say it's clear and it's excessive. Okay, excessive, and it is not foul smelling and there is no blood. So what is the suspicion? Most likely this is amniotic fluid leakage. Okay, most likely this is amniotic fluid leakage. So how are you going to confirm this is okay? We have approached our most likely diagnosis that this is a rupture membrane, and because of that she is having amniotic fluid leakage, because all the other things are ruled out. Now how are you going to determine whether labor is going to start, has started or not? The best predictor is our cervical length and our fetal fibronectin. Okay, this is very important. Okay, let's just talk about this. Usually what happens is, just a second. Okay, usually what happens is that females come with vaginal discharge. We cannot admit all of them. So what we're going to do is to find out which one of them is in preterm labor and which one is not. So for that we're going to assess her cervicovaginal fluid for the levels of fetal fibronectin. Okay, we're going to check her fetal fibronectin levels, and basically usually this fetal fibronectin is present in the cervicovaginal fluid before 22 weeks. Okay, if it is present between 22 to 36 weeks, remember this landmark. If cervicovaginal fluid has fetal fibronectin between 22 to 36 weeks and the value is more than 50 nanogram per milliliter, this is basically specific and sensitive that preterm labor has started or is about to start. Okay, You can also have a look at her cervical length on transvaginal ultrasound. If it is less than 2.5 centimeters, then this also means value 2.5 centimeter, and this also means that labor is about to start or has started. Like, because effacement has occurred now, dilatation effacement has started. So, if a female comes with symptoms of rupture of her membrane, how are we going to assess whether the preterm labor has started or not? We are going to check at the levels of fetal fibronectin, and also we are going to look at the cervical length. Okay, positive between 22 to 36 weeks, and cervical length if it is 2.5 centimeters. The value is 2.5 centimeters. If it is less than 2.5 centimeters, this means that the placement has started on transvaginal ultrasound. Okay. Okay. Now, what were we talking about? We were discussing the long case. So, what else we are going to ask? We're going to rule out chorioamnionitis in a patient who comes with this leakage, fever, any tenderness, check her heart rate, any tachycardia and stuff like that. Okay, rule out infection. It's very important to rule out infection, because if the infection has started, you have to deliver her right away. You cannot keep her with ruptured membranes and infection. That's very dangerous. So do a vaginal swab. Okay. Now, many very important history points are infection with bacterial, um, bacterial vaginosis. If she is having, okay, basically many infections can cause preterm labor, including Trichomonas vaginalis. That is also important. But bacterial vaginosis, if someone asks you one specific infection associated with preterm labor, that is bacterial vaginosis. And also you have to ask her about the history of any cervical procedure. Has she undergone any cervical dilation? Has she undergone any cone biopsy for her cervical intraepithelial neoplasm or stage 1 1A carcinoma, stuff like that? So cervical procedures or bacterial vaginosis. And one more important thing is history. Does she have any history of preterm labor? Does she have history of premature rupture membrane? Does she have usual excessive vaginal discharge without pregnancy? Because that basically signifies cervical incompetence. Okay. Now we have asked all these questions. Now we are going to study the theory. Okay, so we have already discussed all these things, that the normal term labor is at 37 weeks, and if it is before 37 weeks, then that is preterm labor. And early is less than 34 weeks, and late is between 34 to 37 weeks. Okay, and fetal lung maturity is achieved by 34 weeks. That is our main concern in case of preterm labor, because lungs are not mature before 34 weeks. Okay, so if it is after 34 weeks, you are less worried about the lungs. And surfactant is synthesized in lungs by 20 weeks, and it appears in amniotic fluid by 28 weeks. Has nothing to do with our case, just a fact, a random fact. Okay, so what causes a preterm labor? This is something that you don't have to memorize. It's just a basic diagram can help you remember this. Okay, this is the fetus. Okay, so basically anything that causes, okay, first this is the uterus, and let's say that this is the, don't mind my drawing, this is the cervix. Okay, and let's say that this is the, like this, the membrane, it has not broken yet. Okay, so anything that causes uterine distension is going to cause pressure downwards also, and it is going to cause the water to break, membranes will be ruptured. So what are those things? First one is excessive fluid polyhydramnios, the first cause. Second cause that can cause uterine distension is a lot of babies in the uterus, multiple gestation. Okay, so multiple gestation. And another cause can be if she has, any coexisting tumor, any chorioamnionitis or any fibroid. You also have to be concerned with that. Okay, and what can be other causes? Let's move towards the cervix. As I mentioned before, you have to ask her about the history of any preterm labor and history of any cervical procedure that has, if a cervical procedure has been done, because cervical weakness, you know, or any procedure that led to cervical incompetence, they are also causes. Okay, so these things we got done with them from this diagram. One more thing, we talked about uterine distension and causes that are going to cause weakening of the cervix. Then one more thing is, if the uterus is, let's say, abnormal by birth, that female had an abnormal uterus, let's say that she had a didelphic or uterus, arquiroseptate uterus, let's say that she has a septate uterus like this, is there a lot of space for the baby? No. So separate uterus also lead to preterm labor. Okay. Now, other than this, if she has had an infection, chorioamnionitis infection, as I already discussed about bacterial vaginosis, and I have discussed the Müllerian abnormality. Now, hemorrhage. This is very important. Basically, a female who is having an antepartum hemorrhage, mostly a placental abruption. As I said, that you have to ask her about blood in her discharge, because we are supposed to rule out placental abruption. And in placental abruption, we have a very specific woody uterus. So placental abruption, suddenly the placenta got detached. There was a lot of blood, excessive pressure, downward pressure, membranes ruptured. Okay, and also if there is any sort of environmental stress, that is also causing FGR. So all of these are the causes of preterm labor. So we just discussed the causes of preterm labor with the help of a beautiful diagram. Don't judge. Okay. Now, how are we going to manage the patient? Let's say that the case that I discussed did not have labor. It was only the case of rupture of membrane, and I talked about the questions that we are going to ask, but we are proceeding with the topic now. So we also have to discuss preterm labor. So what are we going to do? We are going to give we are going to give tocolytics. Why? Because we need to buy time for a maturation of lungs. So what can we use? There are a lot of options for tocolytics. We can use beta sympathomimetics, we can use ritodine, we can use magnesium sulfate. It is very important. One very important MCQ is that it is very important for neuroprotection. And one other question that they ask is, how does it work? It basically modulates the calcium channels. Okay, because calcium channel blockers are also separately used. So there are two drugs that are acting on the calcium channels, calcium channel blockers and magnesium sulfate. Then you have NSAIDs. Now NSAIDs are contraindicated if gestational age is more than 32 weeks. Always remember that. Okay, less than 32 weeks you can give it. Next, best therapy. What are, okay, many other drug options are also available. We can also use calcium channel blocker. As I mentioned earlier, we can use oxytocin receptor antagonist, that includes atosiban. We can use corticosteroid therapy is something that we always use for lung maturation. We can use dexa and we can use beta. Now these doses are very important. What is the dose of beta methasone? We basically give, okay, yeah, we basically give 12 milligram, two doses, 24 hours apart for beta. And for dexa, we give 4 doses of 6 milligram, half. This was 12, this is 6, but we are giving 4 doses, double doses, and they are 12 hours apart. Okay, so always remember for beta and dexa, which one is better? Basically, different trials have been conducted, and dexamethasone actually, wait. Okay. Dexamethasone actually has a sulfide preservative that is linked with neurotoxicity and should be avoided. So dexamethasone should be avoided. So let's just prefer beta, because this